All right. So welcome everyone. Muy buenas tardes. Good afternoon. My name is Leopoldo Cavazza. I am the co-director of the Center for Mental Health Services Research along with Byron Powell. And we're very excited to have Dr. Kiara Alvarez today doing our monthly seminar for November. And just to, before I introduce her, I just want to do some housekeeping comments. If you have any questions, please put them in the chat. I'll be monitoring throughout the talk, and then we'll have at the end 10-15 minutes for question and answer and discussions that we can do, and then you can unmute yourself during that time. This is our last seminar of the year. We will have a new schedule for starting in the spring semester that we will be emailing that to everyone. So be on the lookout for that great email with a great lineup of speakers for next semester as well. So today we are very fortunate to have Dr. Kiara Alvarez. She's a licensed clinical psychologist, a PhD. She's also a research scientist in the Disparities Research Unit in the Department of Medicine at Massachusetts General Hospital, and an instructor at Harvard Medical School. She's also a fellow Puerto Rican that I learned today, so this is always great. Her research and clinical work focuses on addressing child and adolescent behavioral health disparity with an emphasis on the Latinx and immigrant youth mental health, suicide prevention, and family and community level interventions. And today, Kiara is going to be talking about early interventions for suicide risk among Latinx immigrant youth, bridging clinical, family, and social context. So with further ado, I will give control to Kiara. And Kiara, you should be able to share your screen now.
Wonderful. Thank you so much. It's great to be here. Thanks so much for the invitation. Let's see. All right. Can everyone see my screen? Just go on to slideshow now. All right, wonderful. So I'm excited to be here today. I was telling Dr. Cavazza right before that the last presentation I did on this was a 6-minute presentation. And so it's really nice to get a chance to actually spend some time and really get a little deeper into some of these topics that I'll be talking about here today. I absolutely welcome questions as well as input and dialogue. I'm still learning so much about this area, and I love to hear both from people that have other knowledge about it to share, or also coming from different perspectives, that might give some new perspective to the work. So as noted, I'll be talking about early intervention for suicide risk among Latinx immigrant youth. And I would like to start just with my disclosures. Very much acknowledge funding that's been instrumental to the work I'll be presenting today. The first 3 projects that I was directly involved in, my K-23 that funds this work, as well as pilot work from the Bloomberg American Health Initiative, and a different project with the William T. Grant Foundation that I'll be mentioning on one of the slides. The other 2 studies that I'll be talking about here are studies that I was not part of conducting, but that I have been doing secondary data analyses on. And as an overview, I'll be talking about these 5 different areas, starting a bit with the background on demographics and healthcare system barriers and sociopolitical context for Latinx immigrant youth, then delving into suicide risk among Latinx youth, and then focusing more on my work in family-based prevention and where that work in progress stands, as well as then broadening out that perspective to the social context. So to begin, some of this will be familiar, to some people in the audience, but I like to start with kind of a baseline of the demographics and what we're talking about when we talk about Latinos or Latinx US residents, knowing that it's a large proportion of the US population, 18%, and that it's a growing population, and so projected to be almost 30% by 2060. 34% of that population is foreign born, so that means actually the majority are people that were born in the United States. 40 million, Latinos speak Spanish at home. And when we look at the youth population, it's actually a larger proportion of the population. So at this point, it's about a quarter of children under 18 in the US. And we see a lot of diversity in terms of, even though the majority are US citizens, as you see there, in terms of family documentation status. And so we know that there's at least 4.5 million US citizen children that are living in families that have 1 or 2 undocumented parents, which all is relevant to some of what I'll be discussing today about the social context. And so the Latinx community, is an extremely diverse community. And so we use kind of this category in the US to describe people that came from all different countries across Latin America, as well as people of different races, ethnicities, different backgrounds. And one thing that I do like to highlight, because I think we don't talk about it enough, is that, we often think about Latinx as speaking Spanish or Portuguese if we're thinking about Brazilians, but it's a very linguistically diverse region. In particular, there are hundreds of indigenous languages, and you see that some of these languages are spoken by millions of people. And as migration patterns have changed, we have really seen more migration, particularly in certain areas of the US, from people whose primary language might be Quechua, for example, and where we see the language access disparities that impact Spanish speakers, are even more pronounced in this context. And I also want to mention, there are also different sign languages by country. And this is an experience that I had myself as a psychologist of working with a family in which both parents were deaf and were from the Dominican Republic. And their language, was Dominican Sign Language. And the process of getting for them to be able to access services and for people to even understand that they had different needs than a US, born deaf person who is primarily communicating in American Sign Language was a major challenge for them. In terms of the healthcare system, these are kind of broad overviews, but what we see is lack of insurance. So Latinx children among the largest group of uninsured youth in the US. We also see less comprehensive insurance. So often if parents are undocumented or if kids are undocumented, they may not be able to get access to the same insurance, if at all. We see challenges, navigating the US mental health services and system. It's a very challenging and complex system for anyone, much less if you are navigating with additional barriers of language access. Stigma surrounding mental health, which we know impacts, probably every culture, in the world as a version of this, but that we also know that stigma can be culturally and community specific. And among immigrant families specifically, we really see this fear of using the services that are available to them. So they already have the reduced access to services, but especially in recent years, we just continue to see this ramp up in immigration enforcement. We see this even in locations that were previously considered quote unquote safe, where people may have sort of trusted that there were certain locations that they wouldn't be subject to immigration enforcement. And that has changed. I've heard that from families, even at the level of trusted community organizations, and saying, it's probably just safer for me not to go at all, not to access these services. And there's been a lot of fear about not only the actual regulations coming down, but also uncertainty about what regulations might mean. And so this idea that, with this public charge rule that has gone in and out, of court hearings and things like that, the possibility that they could be denied a documented status in the future based on using government benefits, and people often interpret that to mean healthcare, even though it shouldn't impact their healthcare access. And finally, to get to the sociopolitical context, again, it's a bit of an oversimplification, but I think some of the things that we see are that this context keeps changing for families, and that families have and youth have very different exposure to risk factors depending on their country of origin, the time period in which they migrated, what reason they were migrating, and what their migration experience was. And so, if they arrived in a sort of planned fashion versus if it was a push, out of a dangerous situation, for example, could have a very different context for them. And as mentioned, we see this increasingly restrictive, punitive, and unpredictable policy environment, which has really been over the last 2 decades that this has been going on, but we really see the impact of that on families. And then finally, the impact of hate speech and crimes, racism and discrimination on day-to-day mental health. And so in this broad context, I give that as sort of the backdrop to say, why do we think about suicide risk among Latinx youth? And I'm starting with first saying Latinx youth broadly, because I'll talk about first some of the research more generally, and then try to focus in on those that have an immigrant origin, meaning they were either born in the outside the US or born in the US to immigrant parents. So youth suicide in general, it's the second leading cause of death among 10 to 24-year-olds. Rates continue to increase. They've increased in every age group except the oldest age group between 1999 and 2014. And this is in the context of declining overall mortality, declining homicide rates, for example. And so we see improvements in some areas in public health, and we really see this worsening. So this is a major public health crisis. We know that it's not just about youth that complete suicide, which is something that we want to prevent, but we also know that suicide attempts can cause serious medical complications, and that there's just, reverberating impact for the youth themselves, for their family, for their community. And the challenge that you really have in suicide prevention is the lack of evidence-based treatments that really are shown effective to reduce both suicidal behaviors and suicides. So at this point, based on reviews, we only have one treatment, which is dialectical behavior therapy for adolescents, that has been shown to be effective in 2 unrelated randomized clinical trials to actually reduce suicide attempts. We have other promising treatments and other things that we use, but in terms of really looking at randomized controlled trials, it is still a very evolving situation. So this really poses a lot of challenges when you're thinking about implementing an evidence-based treatment, when you really have barriers to even identifying one to begin with. And when the one that you have is one that is a very, intensive, a very effective treatment, but very intensive, both cost, wise and in terms of family investment. Something that we see is that we really don't have any treatments that address specific mechanisms for youth of color. Youth of color have been very much underrepresented in suicide research to begin with. And that's true across both longitudinal studies as well as treatment research. And when they are included, their particular experiences are not necessarily discussed or analyzed. And so we have a review on evidence-based treatments among children by Pina, Polo, and Huey in 2019 that really gives this update across a number of conditions, including suicide, and really shows how challenging it has been that even in the 10 years, since their prior review, there's been so little progress, and I would say, this isn't due to lack of interest, because there's people that have been working in this area for a very long time and people have developed treatments, but there really seems to have been a very major lack of funding for these studies to be taken to scale and to really put the research into action. So when we think about then Latinx youth, we have this history, which I'll try to cover very briefly here, but just to give a sense that, this is a long history of research. Historically, the focus on this area became because of Latina adolescents being identified as a group with elevated rates of suicide attempts compared to white and Black adolescents. And this was often from youth risk behavior surveys. And historically, Latina girls had the highest rates of self-reported suicide attempts. We actually see a change in the last 2 surveys covering about the last 4 years of Black females having the highest rate of attempts. Which is, very concerning change, where we're seeing a rise in suicidal ideation and attempts among among Black adolescents, both male and female. But historically, the reason for the focus was about a disparity and a disproportionate impact on Latina girls, although we didn't see that in completed suicides, but it was more in the suicidal behavior. We do know among immigrant youth that there seems to be an increased risk of depression and ideation and attempts for 2nd generation Latinx youth, those are that are born in the US, to immigrant parents, compared to 1st generation, which goes along with a lot of other literature on this idea of healthy immigrants, that people are actually healthier when they arrive in the US than once they've been here a while. But there also has been research showing that youth that arrive in the US fairly early in life, say before 6 years old, have a pretty similar experience to US born. Another area of concern for disparity is just in access to services, where there's not that many service use disparity studies in suicide prevention research, but of the ones there are, we see much lower rates of service use for Latinx adolescents compared to white adolescents. We can kind of extrapolate from the literature on internalizing disorders that immigrant youth generally access mental health services at lower rates than non-immigrants. And a very recent study did look at youth with elevated suicide risk recruited from emergency departments, so really youth that should be receiving services, and finding that racial ethnic minority adolescents who were kind of analyzed in that study as a group had lower odds of having past mental health service use. So in my very brief overview, this is more for those that are interested in kind of understanding the history of this work. There were a number of studies that were done and then developed into conceptual models starting in around 2001. And so you may recognize a familiar name here with Dr. Cabasa in the 2nd article. And this was one of the seminal articles really establishing a conceptual model for why Latina adolescents might attempt suicide at the rates that they do. And so you also see several other reviews, including a recent one that focused on service use among Latinos and some potentials for intervention there. And then you also see Dr. Zayas's book, Latinas Attempting Suicide, that was based on a study in the early to mid 2000s, comparing the experiences of Latinas that had attempted suicide versus those that had not in New York City. So, not being able to give the full background on each of these works, I just wanted to kind of highlight that there are some kind of themes that carry through. One is the idea that it's really about looking at this as an ecological and developmental perspective, that the interconnectedness of systems, including the family system and the interdependence of people is an important characteristic of understanding, why there might be disparities in rates of attempts. The importance of family conflict, communication, and support very much comes across. We know that family conflict is a risk factor for suicidal behavior across racial ethnic groups. It's one of the things that comes up most commonly and consistently in studies. But we also know that the role of the family for Latinx youth may be, culturally unique, or at least distinct from, cultures that are more individualistic, and that there can be particular conflicts and communication challenges that arise in the US context for immigrant families. And I will talk a little bit more about those. The impact of sociopolitical and contextual stressors is acknowledged in these models, but it is something that is less studied in empirical research since then. And resilience practices in Latinx communities, particularly how these might be applied to suicide prevention, are also less prominent in the literature. So they're talked about, but again, they just show up a little bit less in studies and in kind of assessments that wind up in these larger data sets that we analyze. So building on that, the frequently discussed factors include things like acculturation stress. And so the idea that moving to a new country brings with it a number of stressors, which actually can carry over into the second generation. Things like language differences, experiencing discrimination, having a sense of the US as a closed society that is not open to you as an immigrant can be some of the domains. Intergenerational cultural conflict is one that I focus on because it comes up a lot, in those contextual models, this idea that adolescents and their parents may acculturate at different rates to the context, and that can create family conflict. And the reason it's particularly important in adolescence is because you already have a context where adolescents and parents are clashing, and this is developmentally typical and expected, but it can become kind of amplified by this sort of differences in what they see as, the culturally appropriate behavior and personal goals and those sorts of things. Familismo or familism, which is a cultural value that really focuses on family closeness, cooperation, and being sort of deferring to your elders. The idea that gender roles, may play a role. And I know in Dr. Zayas's conceptual model, there was a lot to discuss about gender roles and what's expected of Latina girls, both in kind of the cultural, family context, as well as in the broader society. And then finally, cultural expectations about how distress gets expressed, is something else that comes up as a difference. And this is, true in both in terms of the language people use and also what might be acceptable or not acceptable in terms of expressing emotions. And then finally, I'll wrap up this part, which is my sort of, broader conceptual part, to just say, well, why would this be different for immigrant youth specifically, or immigrant origin youth? And I will just say that I think, part of this is sort of putting the pieces together, but we have evidence, in the last 10 years about risk for emotional behavioral problems among certain groups, right? So among immigrant students that are foreign born, among children of undocumented parents and children of deported parents. These are children that are having an experience that is very different than, for example, for me as a Puerto Rican being in the US and not having to have these concerns about a family member being deported. And we also see that, migration patterns change. And so we do have migration patterns of youth arriving in the US, having experienced both before and after, and even during the migration process, having experienced high levels of trauma, being separated from family members during the process of migration. We've just seen a large increase in, unaccompanied youth arriving in the US, as well as family units arriving in the US, where before it may have been more adults coming for economic opportunity, but the family would remain in the home country. And, for adolescents, we see this idea that, if depending on their context, if they have a sense that they don't have this future in the US, that they're isolated and excluded, that they don't have a sense of hope about what their future might be. Again, this is not that everybody is feeling this way, but that there are kind of political and social contexts in which youth can be made to feel this way, and that maps onto things that we would get concerned about for suicide risk. So I'll go into a little bit now on my research, but I wondered if there are any questions. I know that's a lot of overview type material.
Okay, I do have a question. Did I understand correctly that out of the evidence base or the trials that we have around trying to reduce suicide behaviors and attempts, DBT for adolescents is the only one that is the only one that's been sort of it's an evidence base and there's multiple trials on it. No other ones rise to that level of evidence?
Yeah, exactly. And so that comes from a review by Cassie Glenn, Dr. Cassie Glenn and colleagues, where they've really looked at it from the perspective of kind of the criteria where a well-established treatment has to be established in 2 separate randomized controlled trials by 2 unrelated groups. And DBT is the only one that has risen to that. So there are others that are in kind of the promising category. There are some that have seemed promising and got downgraded a bit. But that's, I believe the most recent one is a 2019 review. And then I should say that, it's not in the slides, but for example, in the category of not having any culturally specific treatments, Jovanska Duarte Vélez has piloted an intervention for Latino youth and Latinx youth with suicide attempts, and is currently has an RCT funded by NIMHD. For that work. And so I think that, there's promising work underway, but in terms of what has been sort of established to date, it's only DBT for adolescents.
And Duarte Vélez work, if I'm not mistaken, she's actually developed it in Puerto Rico and then brought it to the United States, if I'm not mistaken, right?
Yes, that's exactly right. She developed it in Puerto Rico. So she has there's a few papers she has about that early treatment development, and then she piloted it both there and in Rhode Island. Yeah, so she has a pilot that had wrapped up and that, and now has an RCT underway in Rhode Island as well. Yeah.
Excellent. No, it's really shocking to see, the lack of evidence for this issue in youth in general, and lack of really good treatment packages for this. So anyway, that just caught my attention, not knowing the literature.
Yeah, it was something I was very shocked by too when I learned it. And it is, and I think there's been a lot of work in recent years. There's a kind of a flurry of activity, I think, at this point. And so hopefully more things come forward. But it is surprising just in the overall field of suicide prevention, because even when you compare it, when you compare it to depression treatments or anxiety treatments, really been a challenge.
I was shocked by that too, Kiara. I felt ignorant not knowing that DBTA piece. Can you speak to the NIMH portfolio and that flurry of activity? Like, are most of those studies focused on intervention and services research, or is it still like basic science focused studies on suicide prevention, or more mechanistic studies at this point?
Yeah, that's a really good question. I'd have to say, I'm much more familiar with the services, and prevention portfolio, and that's more of the work that I follow. But NIMH, has definitely invested a lot in suicide research, especially in the last, I would say 5 or more years. It's a major priority for them. And I think, overall a major priority across multiple institutes. So they have really invested a lot and put a lot of effort into, convening expert, panels on different topics and things like that. So they are funding, I think there's kind of a few different areas. And so certainly they are funding several of those RCTs. Jovanska Duarte Vélez's work is funded through NIMHD. Others might be funding. I think one of the goals, and I think has come across a few different institutes, is also being able to look at existing trials and do secondary analyses for suicide outcomes if they have them, because of the possibility that there may already be, sort of treatments that haven't quite been identified as being effective for suicide prevention. So that's, I think, one big thing that they have been really focused on, is trying to both, stimulate that kind of secondary data analysis, as well as have intervention data combined across studies. So there's one, I think, big project happening with that now, that they've funded. And, and so I would say there's both an emphasis on the RCTs, but there's also an interest in implementation, right? So I think that's the biggest challenge for the youth side of things, so really when I say, there's only one effective treatment, that's in the youth space, right? And so it might look a little bit different on the adult side, although there's still a lot of challenges. But I think the biggest challenge is this idea of trying to, implement and get things out into usual care when we don't necessarily have, very tried and true, options to do that. And so there's a kind of development and implementation happening at the same time, as well as, I think, some investment in medications, so there's some ideas about, I think, different kind of rapid acting medications to reduce risk. And those are, I think, more on the side of more looking at the biological mechanisms. Yeah.
That's super helpful. Thank you.
Yeah. Okay, so I'll continue. So thinking about family-based prevention, this actually links to that question about NIMH, because we know, again, that across epidemiologic studies, we have these findings about family conflict increasing risk, about communication and connectedness being protective factors. So really thinking that the family is pretty important in this. And in that same review that I mentioned by Dr. Glenn and colleagues, they find, that promising suicide interventions all include the family in some form. So even if it's an individually focused intervention, they all generally have some component of involving the family, and some do that, in fairly intensive ways, up to having sort of conjoint, treatment options for the family. And this research that was led by NIMH program officers and published a few years ago also looked at preventive interventions that were delivered in childhood. These were not suicide focused at the time, but did secondary and data analyses of those. And so there were several papers kind of showing some promising results, where if they could do long-term follow-up, in some cases found lower attempts, in other cases lower rates of ideation. And so this idea that, some of these preventive interventions that are more around parenting or around supporting families around grief or other things in early childhood could really have these long-term upstream effects. And so in the case of, when I'm thinking about family-based interventions as a family therapist, where you'd really work with the family system altogether, if we think again about that idea about intergenerational cultural conflict being probably a key mechanism that wouldn't necessarily be addressed in a non-culturally tailored intervention. We know that it's being addressed in other interventions, substance use, for example, I think has been, this has been a big focus in the substance use prevention literature for many years. And then language, I think, is another key aspect, because what we, know and often deal with in clinical settings is that, parents and children don't necessarily have the same level of proficiency in the same languages. And so they can experience barriers to communication, especially around emotional topics. If, say, the child feels more comfortable in English and the parent feels more comfortable in another language. And we know that there's this lack of bilingual therapists and interpreters services, to meet mental health service need. And that's sort of true, I think, everywhere, including places that have many bilingual therapists. There still often is just not enough to meet the demand. So in my particular study, this is an NIMH K23, and so the goal of the study was really about developing a brief family therapy program. And this is meant to be for adolescents that are experiencing thoughts of suicide. So this is suicidal ideation. It's earlier in the continuum than a suicide attempt. And the idea is really that it's a preventive intervention, thinking that by addressing this sort of larger population of youth that are experiencing suicidal ideation, this could have beneficial impact, on them in the long term. And the goal of it is really to build upon the family and cultural strengths. And so having a strengths-based focus that would improve communication, reduce conflict. And that was originally meant to be a series of in-person family meetings, but now, of course, is being adapted for telehealth, which I'll talk about a little bit towards the end. And so in my intervention development process, the parts that are in blue are the parts I've sort of gotten to so far, and the rest of it, was meant to start at the beginning of this year, but has been delayed. So ideally, the idea and what I'll be presenting on is, there's synthesis of sort of the evidence-based practice elements. So what are the components that should go in this intervention? Looking at some longitudinal data sets for risk and protective factors, conducting focus groups with immigrant origin Latinx parents and adolescents. And then finally, the part that we have in progress is to really test the intervention with family feedback and then conduct a pilot trial. So in the evidence synthesis, we looked, my focus was on sort of 3 areas of literature: family therapy and resilience models, suicide prevention, and immigrant youth mental health. And these can overlap sometimes, but they also are, fairly distinct literatures. And from that, selecting 4 intervention targets: safety planning, which is essentially the foundation, of any suicide prevention intervention. And that includes means restriction, which is also, I think, one of the few strategies that we see that can be very effective. So reducing access to firearms or to medications, for example. And that's something that in the family context can be, part of an educational process with families. Reducing family conflict, as well as intergenerational cultural conflict, and improving parent-child communication. And ultimately, it's an integrative model, and so it's really a brief collaborative family therapy that combines cognitive behavioral, narrative, and multicultural therapy approaches. So in the secondary data analysis, I won't get to go into detail on these. We are working on a couple of papers, but I'll just give some of the takeaways that we essentially used then for the intervention. But I do want to highlight that these were 2 studies that were to different groups of investigators. Dr. Robert Roberts, who had the Teen Health 2000 study in Houston, where he oversampled Black and Latinx youth. And they had 3 waves over 6 years, starting in early to late adolescence. And then the Boricua Youth Study, which I got to join in working on as a postdoc, and so have been able to do some analysis with. And this one is actually a longitudinal study of Puerto Rican youth growing up on the island in Puerto Rico and in the South Bronx. And these are 4 waves over 17 years. So there were 3 waves in sort of childhood and early adolescence, and then there's 11 years later a follow-up when they're in young adulthood. A major limitation that I'll say is that it's very difficult to get access to data on first-generation immigrant youth that also includes suicidal behavior outcomes. So in general, it can be hard to find longitudinal studies that have suicidal behavior outcomes. I mean, there's good reason not to collect that data or to exclude people that disclose suicidal ideation or behavior. So you often don't find it in studies. And then, even in these studies in Teen Health 2000, the majority of the Latinx youth are, second generation or later, Mexican youth growing up in Houston. And in the Boricua Youth Study, they tend to be pretty established populations, both in the South Bronx and in Puerto Rico, where the families have been there for several generations. So again, I can't go into detail, on all of what we did, but I think the key takeaways for me with the intervention were, individual level characteristics, sleep being one that I actually wasn't thinking about as much when I started the study, but has came up as important, and is also being addressed in other interventions as potentially a suicide prevention intervention to really focus on sleep and sleep disorders. Of course, psychological symptoms and coping. But that at the family level, we confirmed that focus on parent-child relationship as a protective factor and family stress, as a potential risk factor. And then I think importantly, because my intervention focuses on the family system, but we really see the impact of this context and of neighborhood and economic stress in one study, of an adverse school environment with our findings from the Boricua Youth Study, and of exposure to violence, all of these being potential risk factors for later suicidal behavior. I also worked with a colleague to conduct a chart review of initial evaluations for 32 unaccompanied immigrant minors. So this was an example of a group where we don't necessarily have, easily accessible data on, but we conducted a chart review for youth that were being seen by a social worker for school-based mental health services. And we really see, it's a clinical sample, they were referred for care, but given that they were being seen in school, they're very highly, they're an acute clinical sample. We had over half of them reporting sleep problems. Almost half of them reported having had suicidal ideation or attempts at some point. Nearly all of them reported trauma on initial evaluation. which was really striking to us, partly because it was only the initial evaluation. And so we actually knew that most of these youth had not disclosed their full histories until much later in treatment. And many of these, 3/4 described prolonged periods of living apart from their parents. Relationships with family members were a source of conflict, but were also an important source of support. And so often, the same family members, right, could serve both roles. And so I think it highlighted to me that importance of addressing those impairing, symptoms, as well as involving families, which is harder to do in a school context. But it certainly, just involving families doesn't address the fact that this context, is impacting all of them. Let's see, so then focus groups, we also conducted focus groups, and this was in collaboration with a group at Johns Hopkins, and the PI of this study is Holly Wilcox, and we collaborated across the two sites to recruit parents and youth in both Boston and in Baltimore, which is more of a newer destination area for immigrants. And what we found was really that, again, that we have larger findings in the project, but relevant to the intervention, the themes were very consistent with the selected targets, but parents and youth perspectives differed. So, for example, parent-child communication is something that both groups brought up as being important for suicide prevention and being a stressor. But parents somewhat blamed themselves. They said, oh, it's because I don't have, good parenting skills about being able to talk to an adolescent, or I don't have enough time because I'm working so much. They really thought that it was their fault, if there was a communication problem. Whereas youth said, in general, they were trying to avoid causing stress to their parents, or they were trying to avoid negative interactions. They thought if they disclosed something going on with them, that might lead to more stress or challenges in the family. So they really described that the reason for the lack of communication is that they were somewhat holding back. So I think this just highlighted the importance of bringing the family together to talk about these things, right? And really highlighting that the problem is not located in one individual, that this is a family, kind of process to figure out what's going to work best for them, because both groups really wanted better communication, which was important. But again, and I have some quotes to highlight this, we really see these risk factors in the broader context. And these are, I've read this quote a number of times, and it's still very difficult to read, but essentially we have this youth that said to us, so if one of your parents doesn't have documents or papers, all you can think of is when they go to work. Will they come back home, or will they be in their home country? Because you never know when they will get deported. So I guess saying bye means every morning saying bye before they go to work is better than not saying bye before they leave. And, he goes on to talk about his mother, working in Boston, and kind of this context of thinking, okay, I've heard about this happening in Boston, and these are the things that might happen. So when you really, sit, I think, with that level of uncertainty and anxiety and distress, that's affecting so many children, like this young person that shared this history, you really see where, the kind of big, I don't know, at least for me, it just kind of highlights where our big, kind of data analyses of large studies sort of fail us, because we don't necessarily capture, this level of stress that is impacting youth and families. And this is another one from a mom who said, I'll read the English translation, for me in the United States, the stress is always because of the money that isn't enough for the rent that you have to send there economically and work. The women in our countries really don't work the way we work here. So then here you neglect your family for work, and that causes more stress. You think that it only stresses you, but no, the stress stresses the whole family. It affects it. And there's a lot there. There's a lot there about this mom comparing her experience to what she imagines she might have had if she hadn't migrated, about sort of gender roles and expectations. But I think, very importantly, the idea that there's this sort of guilt about feeling like the family's being neglected for work, and that's causing stress in the family, but at the same time, the work is essential to what they are aiming to do for both for their family here and their family in the other country. So bringing it into kind of the present day, that moves us into that pilot trial phase, and this is kind of the model, the idea that you build family resilience through improving communication and reducing conflict. And that, no, this doesn't, directly address a psychological symptom per se, but the idea is that by creating this in the context of the family, then there is this kind of downstream effect of really increasing social support and coping skills and self-regulation, because everyone kind of works together to increase that within the family. And that ideally it's a much longer lasting effect than with individual work, because it's getting reinforced, at home, where, as opposed to just in the therapy session. And the context, that we've taken is both, there's both a sort of skills-based context about planning for safety, about communicating and practicing skills, but there's also a narrative context about sharing experiences, establishing rituals and routines, and really honoring the migration journey, both the past one that the parents went through, but also into the present day with the youth and into the future. And so finding a way to unify those different experiences as opposed to feeling like they are sort of somewhat separate or different from each other. But, the challenge we also face is with COVID, we see just incredible disparities, which I know everyone, is aware of, impacting families, both at the level of illness, but also just the number of social factors and risks that have come along with that. We know that immigrant families, are impacted by the fact that they're excluded from stimulus benefits in many cases, including when there's just one family member that doesn't have a permanent status. Even though that family member is often, paying taxes, they're excluded from any benefits. So even the small amount of safety net that there might be is not present. And I bring that up because I think, we have considerations in adapting to telehealth, but we also have considerations about the new stressors and challenges that families are facing. And, to go through this quickly, I think it's just the idea that, there may be some benefits to doing telehealth, but that family therapy in particular, it's a challenge, and it's a challenge to do it at a time when everyone is sort of overstretched already with technology fatigue and work schedules. And people may have work as essential workers and may still be going to work or may not. And be challenged with trying to reach services at home. So our next steps are really to adapt to that context and to conduct a pilot trial by telehealth. And I think the disparity question is, can we increase equity and access? Maybe this reduces the time and transportation barriers that we know often limit participation in family therapy. Or will this worsen disparities due to technology and internet access barriers? We would like, certainly to move the intervention further upstream, to really move away from clinics and into community settings, to consider somewhat stepped care between community and clinic, as well as to consider whether there's fit for immigrant families from other cultures that have a different cultural context, but some similarities in the social context. And I know we are pretty much out of time, but I think the last piece I'll say is then I've mentioned a lot of moments, places where this kind of broader social context came into play. And I think when thinking about that, we did a project, with youth. This was part of a larger project that Dr. Alegria and I conducted in the greater Boston area. And we had a subsample in this larger project of recent immigrant adolescents, some that had arrived only a few months before. And as much as they talked about stressors, they also talked to us, and this was through photo voice. So these photos were taken by the youth. They talked about individual coping strategies and seeking tranquilidad or tranquility in the outdoors, about support from teachers who created an inclusive environment for them, and particularly about the community organizations and youth workers that help them cope and adapt. And so we kind of move in that to, from family to community resilience. And, I like this illustration because, as mentioned, Dr. Cavazza and I are both from Puerto Rico, which really was impacted, in a horrible way a few years back by Hurricane Maria. And when the government, at all levels failed people on the island, they created these centers of mutual aid. And this is sort of an artistic depiction of one of these centers. But the idea is that these were really places where people gathered to make food, and you see somebody building, solar panels and planting. And this idea that this is really depicting a community where people thrive through support from each other. And so the question is, how do we build, our interventions into that type of context, right? And so I think the final thing I'll say is that in suicide prevention research, we certainly need the cultural competency, but we need structural competency as well. And this comes from Metzel and Hansen, the idea that we need to address how societal structures, including both our mental health care system and our research hierarchies, produce inequality and produce conditions where we have to do something like prevent suicide, because there are broader conditions that are pushing us in that direction. So I will stop there and just say thank you. There's so many people that I have, supported me in this work along the way and that do this work with me now. And I'm just also very grateful, certainly to IRI and to all of you for inviting me here.
Excellent. This is great. This is great. So actually, there's a couple of questions on the chat. I'll get to them, but I do want to jump in because I'm very glad that you have moved and thinking about sort of the community level elements here. and how to bring community resilience and approaches, Dr. Alvarez, because I think that's a really important space. And your data is indicating, if I understood correctly, there's several like social conditions that could really be addressed, the school environment, the financial stressors, how to address immigration problems, all of those, I think, as a community level element, I think is really important. So I'm really glad you're thinking about that, because there's a long history, and you're aware of this, I think, of a lot of family-based interventions for risk behaviors among Latino. That some of them are really great and very well done. The groups in Miami and in New York. There's a great one that I'm thinking of, Entre Dos Mundos, which is helping immigrant families, like how to best acculturate and understand, but pushing them towards how does this impact in suicide attempts and behaviors and other components, I think will be really important. So this is, I really, great work on pushing this even to a whole different level, that I thought was very nice.
Thank you. Thank you. Yes, and I think that is very important to say that it's a long history of family-based interventions in sort of Latino, Latinx mental health. And, Familias Unidas, which is another one that was developed in Miami, is one of the studies where they did sort of this long-term, follow-up about impact on suicidal ideation and attempts. And they actually found an effect only for those that had worse parent-child communication at the beginning. So it was a pretty promising finding. But I agree that I think the challenge we've had with suicide prevention is that at a certain point, there was this kind of idea that makes sense, that if you treat the underlying mental health condition, then you will have a good effect on preventing suicide. But that actually has not turned out to be the case. And we actually have, I think, this context where suicidal ideation and behavior is much more complex than that, and is not necessarily always linked to individual mental health symptoms, but is also linked to aspects of the broader context and personal experience.
For sure.
So yeah.
And just one last thing before I get into the question, there is a great work being done in school environments. Ron Astor, he used to be at University of Southern California. He's at UCLA now. I don't know how you measure that in the study, but the school environment, they're finding a lot of links with a lot of different outcomes. I just read a paper that he's published on homelessness and the impact that school environments have on children and adolescents who are homeless, and the importance of that school environment that could create lots of support, but can also create lots of problems.
Right.
So very interesting.
That's great. I will definitely look into that. Thank you.
So I have a couple of questions here in the chat that are coming fast and furious. This is great. So Daniela had a question. What if the family isn't wanting to participate, especially considering the low rates of service utilization in Latinx population due to the prior barriers that you mentioned? So how have you been addressing or understanding that? And Daniela, if you have something to add, that would be great if you do. But yeah.
Mm-hmm. Yeah, just to on that. Oh, sorry, you go.
No, go ahead.
Oh yeah, just something. So I worked as a clinician in the Bronx for a bit, and a big barrier that I found was one, like DBT sounds great, but impossible to get anybody into. And two, like a lot of the times the family, because of that family conflict, especially like, the stigma of mental health and engaging in mental health treatment, a lot of I worked at a community college. A lot of the students were scared to even utilize their parents' insurance to go and get that mental health treatment because of how they would respond.
Mm-hmm. Mm-hmm. Yeah, I think it's a major challenge. I think that very much, the people's interest in family therapy versus the actual, being able to follow through on it, can be a huge challenge because of schedules. Interestingly, I know several clinicians that have said that they have more family involvement now with telehealth because family members, kind of go out during a 20-minute lunch break and, and call them, and people are sort of more connected in that way. So it's a kind of an open question right now that we're looking into. But I think that is a big part of the reason why ideally I'd like to move further out into community settings, because I think in our focus groups, parents really talk about, they want mental health services. They do want to hear from mental health clinicians, but they want to do that in settings that are familiar and comfortable for them. And I found even just in the focus groups that, parents have so much knowledge to share with each other, which is something that I already knew, but even on suicide prevention knowledge, they were just very informed in many ways. And so that I think peer context is really critical. And I think the last thing I'll say about that is that I've also just spent a lot of time thinking about this question of, how can you make family therapy something that people want to do, right? Something that's enjoyable when you go, because I think sometimes, and I mean, you know, if anyone has participated in therapy, I've had this experience as well myself, just as a person going to therapy, not just as a clinician, which is that it's very hard. You know, you're going and you're doing something and you're taking time out of your day, but you're also delving into things that are very difficult sometimes, and you can kind of have this avoidance of it for that reason. And so I try to think about that a lot when I'm seeing patients, about what are the challenges to even getting in the door, and to think about, if I'm having a family intervention, like what would be something families would do where they'd leave feeling good and feeling good about the time they spent together. Which I've seen in interventions with younger kids quite a bit, right? With something like parent-child interaction therapy, where people can actually really start to enjoy, you know, playing together and being in the room together. So how do we create that experience for adolescents and their parents, you know, where they can have that in vivo experience of enjoying each other, you know, which is what people want, right? For the most part. So I think it is a big challenge, but it's an important one to think about, because I think often families, you know, do want a service, and yet, you know, the services we provide or the context we provide it in doesn't quite meet that need or that possibility for them.
I have another question here from Luis Miguel Sanchez Loyo. How do immigrant organizations participate in reducing family and social conflicts? Given that one risk factor is parental mental health, how have you dealt with this in your work? And Luis, if there's something else to add, please, if you can unmute, that'll be great.
Oh, it's okay.
Yeah. Well, thank you, Luis, for being here today. It's great to see you. And yeah, I think, you know, organizations that serve immigrants are a very important context, I think, to provide these services. And actually, somebody and in Chicago, Dr. Dana Rush, and I'll put her name in the chat, is actually doing some really interesting work in this regard of looking to train people working in these organizations with mental health information, so that even though they're not mental health professionals, they can still address some of these needs. We heard about this as well in Baltimore from Parks and Recreation employees, where they said, you know, they're running these programs and they're often hearing from families. Families are coming to them to ask for their advice, and they're wondering, you know, how do they get the training that they feel they want and need to be able to respond to it. So I think there's quite a need, because I think often people are going to the places where they feel most comfortable. And these organizations that are working with immigrants are really a major space for this. So I think they can be a very important part of the solution, and maybe, you know, are often not necessarily getting, you know, the kinds of services and, you know, investment that they might need, because they are also extremely stretched. And so I think about, you know, one of the organizations I collaborated with, for example, I recall being there for a meeting, you know, the day after the massacre in El Paso, of, you know, largely of Latino population. And, you know, they just do incredible work. You know, they were doing interviews with Univision to speak directly to the community. They were working with trauma among their own staff, among the kids that go to their organization, among, you know, community members walking in. And so really seeing that context and how stretched those organizations are and how hard they work, they're an important place to, I think, really provide more resources and more support. And then parental mental illness, I think in this case, we are really addressing it by having it be a family-based systems intervention, where the focus is on what can everyone in the family do, you know, to be able to get the support and the services they need. But, you know, with that, it's also figuring out then, are there additional referrals, you know, that they might need beyond that, to really be able to get the parents the support they need. Because you're right, it's a very important risk factor.
And Kiara, I think you mentioned, and Luis, this is a really important question regarding the migrant organizations as an important platform, thinking about implementation later on, or as you're developing, how would this fit within those agencies, given all the restraints and issues that come up? I think it will be very important to make these interventions and your family-based intervention, Kiara, sort of fit with those realities of those. I think that will be very important.
Yeah, thank you. Yes, and I put the name in the chat of Dr. Rush, so if anyone wants to look up her work. Yes, I think that's really important. That's really where the direction of thinking about, you know, community health workers or peers, I think, is the direction I'd really like to go in, because I think often organizations are very ready and willing to offer services, particularly services that are really based within their network, that are empowering, to their participants, that provide employment opportunities. And so I think really finding ways to move it further out and really have it become something that then gets owned by an organization, by a group of people, but where the mental health, clinicians and support can really be coming in, to support that work and to be partners in that work.
Yeah, they become very trusted members of the. Yeah. So Byron, you want to mention your last question? I think you'll have the last word, I think.
Sure, and this may or may not be relevant, Kiara, but I know you've been involved with the Youth Suicide Research Consortium, and I'm sort of only know about that from an arm's length, but would love if you could share more about that, and if there are opportunities for students, postdocs, faculty members to get involved in that work or that network.
Yeah. Yes, absolutely. Yeah, thank you for bringing that up. And I should have brought that up more directly. It's extremely relevant. The Youth Suicide Research Consortium was founded a couple of years ago now by several researchers who then started convening, a variety of people to join the consortium. And so I was lucky to get involved with that work and, get to kind of see their vision come to fruition, because really the goal of it is this idea that diverse perspectives have very much been, and thank you, yes, that's the website, diverse both in terms of race, ethnicity, as well as in sexual orientation, gender identity, that these groups have been really underrepresented in youth suicide research, and that also there are a lot of sort of early and mid-career investigators that are really working in these areas and don't necessarily have shared venues for their work. And so the consortium initially brought together, different groups of researchers to join the consortium, and has sort of developed over time. And so right now, I think a few of the biggest ways are definitely, look at the website. There's blog posts there as well. Follow on Twitter. They have a Twitter account and, share information there. And then our conference. So we actually had our first conference this past year, and it was a virtual conference for 2 days, and we will be hosting another one ideally next June. And so definitely if you kind of keep track of that, you'll get to see, because it was a really incredible, I think, experience for me, just being in this field and getting to see people present from perspectives that are often at sort of the margins, of a scientific conference, and they were really the central focus. And so we have people doing work in a lot of different areas. And then in terms of membership within the organization, I think as a young organization, that's still an evolving process, but there is a membership committee for faculty. And so faculty can certainly, reach out to the committee in that way, and to find out about, joining the consortium. And then we're still figuring out what could be the best, venues for involvement for graduate students. But we certainly have had, the graduate students that, presented at our conference, for example, there were opportunities for people to get involved that way. And we hope, that there will be additional opportunities going forward. But I think even just looking at the bios, of people there, you really might learn about people, that are doing work in an area you're interested in. And I think most people are very open to, being able to discuss that work.
That sounds terrific. And I'm sure you've considered, I hope that NIH or AHRQ or others get involved in terms of R13 funding or other funding for that work. Seems like a really important network.
Definitely.
Yeah, thank you. We're hoping that will be the case in the future.
Definitely. And the National Institute of Minority Health and Health Disparity, I think that the support that they're providing Jovanska, I think it's opening a door within the institute to focus on this also. So Dr. Alvarez, thank you so much for your time today. This is a great presentation. We're really fortunate to have you, and this has been a great talk overall. So thank you so much. And for those of you, we will be posting this in our YouTube channel, and wait for our emails for next semester's CMHSR monthly seminar. So thank you so much.
Right. Thank you all. Thanks for the invitation. Thanks for being here tonight.
No problem.
Thank you very much.
Thank you. Bye. And we stop recording. So Kiara, muchas gracias. Thank you. Luis, muchas gracias. Thanks.
Por nada. Chao.